Homeostasis. Primary homeostasis within the first few minutes, vasoconstriction of the disrupted vessels by contractile proteins in the endothelium, direct smooth muscle stimulation, neurogenic reflexes, and vasoconstrictors. Platelet plug, platelets, adhere to exposed subendothelial collagen, release the contents of the granules such as adenosine diphosphate and serotonin, aggregate to form a plug which seals the bleeding vessel, tamponade of the bleeding by surrounding tissue tension. Secondary homeostasis reinforce the platelet plug by fibrin deposition leading to coagulation. Definition of homeostasis: physiological arrest of bleeding. Vasoconstriction is more efficient in arteries than in veins because arteries contain more muscular fibers. Vasoconstriction is less effective in partially injured vessel, stiff atherosclerotic vessels, large veins, poor muscle coat. Interstitial hemorrhage tend to be less profuse than external or internal hemorrhage. Preoperative evaluation of homeostasis: family history of bleeding tendency, age at onset of bleeding, ask about liver diseases, chronic renal failure, massive blood transfusion, characters of bleeding, defects of primary homeostasis, superficial bleeding, skin and mucous membranes, defects of secondary homeostasis, deep as hemarthrosis, hematomas in muscles, and retroperitoneal or visceral bleeding, excessive fibrinolysis or thrombolytic agents, generalized bleeding from the wound, drain sites or IV sites. Test for homeostasis indications: patients with personal or family history of abnormal bleeding, patients with diseases or take medications which interfere with homeostasis. Tests for primary homeostasis: platelet count, the normal is from 150,000 to 400,000 microliter, and bone marrow aspiration and biopsy. Bleeding time prolonged with platelet and vascular defects. Tests of platelet function, adhesion, release, and aggregation. Tests of secondary homeostasis: prothrombin time, partial thromboplastin time, thrombin time, fibrinogen level is decreased, and DIC, fibrin degradation product FDP and D-dimer, individual coagulation factor assays. Clot stability test evaluates factor 13. Surgical homeostasis: during surgery, the bleeding is controlled by simple pressure, ligation, underrunning suture, diathermy, electrocautery to stop bleeding from small vessels equal to or less than 3 mm in diameter, whether unipolar or bipolar, clips, laser, repair of injured vessels. Excessive operative and post-operative bleeding causes inadequate surgical homeostasis. This is the commonest cause. Hemorrhagic diathesis not detected post-operatively, as coagulation profile could be normal even with the deficient factor level less than by decreased by 20%. Acquired intraoperative coagulopathy such as DIC, massive blood transfusion. Management: replace the amounts of blood lost, PT, PTT, and platelet count, fresh frozen plasma 3 to 4 units initially, and platelet transfusion. Raise platelet count to more than 50,000 per microliters. Correct hypothermia and acidosis. Proper surgical homeostasis. Shock: hypovolemic shock. Etiology: diminished blood volume secondary to loss of blood as internal or external hemorrhage, plasma as in burns, acute pancreatitis, and peritonitis, sodium-containing fluids as in severe vomiting, diarrhea, intestinal obstruction, and high-output intestinal fistula. Definition of the shock: state of inadequate tissue perfusion with decreased oxygen delivery and impaired cellular metabolism. Classification: peripheral circulatory failure and pump failure. Peripheral circulatory failure: hypovolemia, maldistribution, neurogenic, anaphylactic, septic, and endocrinal shock. Pump failure: cardiogenic, obstructive shock, tension pneumothorax, cardiac tamponade, or massive pulmonary embolism. Patient may have a combination of 2 or more types, as in trauma victims, and hypovolemic shock is due to blood loss plus obstructive shock from tamponade due to bleeding in pericardium. Pathophysiology of the hypovolemic shock: sympathoadrenal response, microcirculatory changes, cellular derangement, acid-base imbalance, effect on individual organs. The sympathoadrenal response aim to stop bleeding and divert blood to critical organs. Neural and endocrinal factors as in hemorrhage. In page 99 and 100, we're going to explain them later. Microcirculatory changes: catecholamines, precapillary sphincters constrict, less blood enters, sluggish capillary circulation. Untreated hypovolemia leads to hypoxia. Under ischemic conditions, more capillaries open, leading to further slowing of capillary circulation, blood sludging, spontaneous blood coagulation. If extensive, this leads to DIC. A sluggish circulation and DIC aggravate tissue hypoxia and affect the function of capillary endothelium, leading to leakage of large protein molecules along the huge amounts of fluids into interstitial space. Bleeding into third space reduces blood volume. Cellular derangement, lack of oxygen, anaerobic glycolysis, lactic acid, and with persistent hypoxia, cellular functions start to deteriorate, sodium-potassium pump failure, accumulation of intracellular water. Result, rupture of lysosomal and plasma membranes leading to cell death, vital organs initially spared but lastly affected, leading to irreversible shock, acid-base imbalance, shock, lactic acid accumulation and renal failure leading to metabolic acidosis, effect on individual organs, multiple organ failure. On the heart, myocardial contractility is impaired by decreased coronary perfusion, direct myocardial depressants such as cachectin 1, leukotrienes, and PAF, released in trauma, tumor necrosis factor from hypoperfused gut, GIT, translocation of bacteria and endotoxin from the ischemic gut into circulation leading to septic death, ischemia of gastric and duodenal mucosa leading to stress ulcers and bleeding, the liver, ischemic hepatic dysfunction, renal function, prolonged hypotension leading to sympathoadrenal response decreasing the total renal blood flow, intrarenal blood shifts from cortex to medulla, excess renin, leading to increased angiotensin II, aldosterone, and ADH, decreasing the glomerular filtration rate, increasing tubular reabsorption of salt and water, and this all leads to acute tubular necrosis. Pulmonary response, acute respiratory distress syndrome as a part of multiple organ failure. Clinical picture, same as hemorrhage. Treatment, stop volume loss as in hemorrhage, fluid resuscitation, two large bore cannulas, one for fluids and one for sampling, lactated Ringer's solution, rate rapid within 45 minutes, between 1 to 2 liters of lactated Ringer's solution are given IV. Advantage, highly effective to determine the pre-existing amount of blood loss or the presence of continuing blood loss. Result, blood pressure returns to normal and is whether stable with minimal blood loss and hemorrhage is not continuing, or transient if blood loss is severe or hemorrhage is continuing. Blood, typed and cross-matched, is given immediately. If blood is urgently required, O negative blood until cross-matching occurs. Avoid aggressive resuscitation and trauma because this may dislodge clots. If massive transfusion is required, give packed RBCs, plasma and platelets 1:1:1 ratio, colloid solutions. In absence of whole blood, use any of the following: human plasma, dextran, albumin solution, and artificial blood substitutes. Pulmonary support, initially oxygen at high concentration by face mask, then adjust the rate and concentration according to the ABG results. If there is respiratory failure, intubation and mechanical ventilation. Monitoring, aim, check the adequacy of volume replacement, clinical parameters, pulse, blood pressure, state of filling veins and capillary perfusion, and finally urine output. Central venous pressure, measure of the preload, it's the venous pressure in the right atrium, equals to end diastolic pressure in the right ventricle. Method of measurement, catheter is placed in the superior vena cava via median cubital vein, the subclavian vein, or internal jugular vein. Pneumothorax, the position is checked by chest x-ray, also to rule out pneumothorax due to accidental pleural injury during insertion, good indicator for circulatory overload or hypovolemia. Repeated hematocrit and hemoglobin assessment, blood gases, oxygen normally between 80 and 100 mm mercury, and carbon dioxide normally between 35 to 45 mm mercury. And finally, we perform the ECG. Not finally, pulmonary artery wedge pressure, PAWP, measured by Swan-Ganz catheter. Aim, early detection of left-sided heart failure. Method, passed into small branch of pulmonary artery until wedged, and the balloon of catheter occludes this small branch. Pressure measured at the catheter tip reflects the pressure in the left side of the heart. Temperature, the difference between peripheral temperature by sensor attached to the big toe, core temperature by a probe placed in rectum or esophagus. Function, assess cardiac output and peripheral perfusion. Positioning, elevation of both legs, maintain the remainder in supine position. Pain relief, early immobilization of fractures, IV analgesics due to poor absorption from subcutaneous or muscles. Inotropic agents, examples dopamine and dobutamine mostly. Indication, no improvement despite adequate volume replacement. Result, both improvement of myocardial contractility while dopamine increases renal blood flow and urine output. core temperature is higher than the peripheral temperature by a gradient that shouldn't exceed 2 degrees Celsius. Any increase in this gradient indicator of decreased perfusion. Atherosclerotic patient who has lost 500 milliliters of blood may manifest with hypotension, whereas a soldier who lost 1,500 milliliters of blood or more could have a normal systolic pressure early. If patient is rapidly treated by adequate volume replacement, vital signs rapidly return to normal. Hypotension in supine position in a fit patient means loss of at least 1,500 milliliters of blood. Hypovolemic shock from causes other than bleeding, as plasma loss and burn or crystalloid loss in intestinal obstruction, doesn't require blood. Infusion by plasma or crystalloids respectively. Optimum urine output is 0.5 to 1 milliliters per kilogram per hour. Normal central venous pressure is 5 to 10 centimeters of water. Then we have irreversible shock. Complete vascular collapse with hypotension, unresponsive to volume or drug intervention, lethal CNS and cardiac dysfunction. Related to age, duration and volume of hemorrhage, pre-existing cardiovascular fitness of the patient, presence of massive trauma. Before the conclusion that irreversible shock has occurred, other causes of failure to respond to therapy should be resolved. Continuing unsuspected blood loss into the chest or abdomen, inadequate volume replacement, occult thoracic injuries, cardiac tamponade and pneumothorax, acute myocardial insufficiency from direct injury or prolonged coronary hypoperfusion. Anaphylactic shock cause allergic reaction to penicillin, sera, Ephetex, dextran. Pathophysiology, type 1 hypersensitivity, antigen antibody reaction, release of large amounts of histamine leading to bronchospasm, laryngeal edema, hypotension, and massive vasodilatation occurs. Treatment, stop the causing agent first. Epinephrine 0.3 to 0.5 milligrams intramuscular, IV crystalloid infusion, IV hydrocortisone, antihistaminics, ETT with endotracheal tube with laryngeal edema or stridor. Cardiogenic shock, definition, inadequate blood flow to vital organs due to inadequate cardiac output despite normal blood volume. Etiology, acute myocardial infarction, the commonest cause, cardiac tamponade, severe arrhythmia, myocarditis, massive pulmonary embolism, improper treatment of hypovolemic shock, high spinal anesthesia, and paralysis of sympathetic supply to the heart. Clinical picture, decreased cardiac output, decreased systolic and diastolic blood pressure leading to compensatory vasoconstriction, cold sweaty skin, inadequate tissue perfusion, metabolic acidosis, characterized by congested neck veins and elevated central venous pressure. Treatment, we have oxygen for respiratory distress, oxygen mask, and for respiratory failure, mechanical ventilation. Treatment of the cause, myocardial infarction if associated with ST, elevated myocardial infarction, PTCA or fibrinolysis, controlling arrhythmias, or pericardiocentesis for tamponade, mechanical support, intra-aortic balloon pulsation device, increased diastolic blood pressure, better filling of coronary arteries, and it decreases myocardial work. Neurogenic shock, there's paralysis of the vasomotor fibers, peripheral pooling of blood, and inadequate venous return. It may occur vasovagal attack or high transaction of the spinal cord. Vasovagal attack, type of syncope, cause hearing bad news, seeing unpleasant events, or severe painful stimuli as blow to the testis or larynx. Effect, excessive vagal stimulation of the heart leading to bradycardia, extensive vasodilatation in splanchnic area, decreases peripheral resistance, fainting, assess venous return leading to recovery. High transaction of spinal cord or complication of high spinal anesthesia. In neurogenic shock, there is hypotension, normal pulse rate, or bradycardia and warm, dry skin, loss of sympathetic outflow.